Let's say you have a patient with diabetes, type 1 diabetes, who is suffering from hypoglycemic episodes associated with exercising. What you have to do with this person is you have to adjust their insulin dose. And so let's say this person is taking a combination of both NPH and regular insulin. Regular insulin is going to be more fast acting and shorter in duration, whereas NPH is intermediate acting and longer in duration. So for this person, there are multiple things you can do. One of them is having them eat carbohydrates before exercising. Another thing you can do is adjust their insulin dose. And so if you're going to choose between adjusting the regular insulin versus the NPH, you want to adjust the NPH, specifically the NPH that they take in the morning. Lower that dose so they can have a more stable glucose level throughout the days, particularly on the days when they're exercising. When to start antihypertensive medications and how many are you going to start? If somebody has a blood pressure of 120 to 129 systolic, lifestyle changes. Once you pass the 130 mark systolic, when you're between 130 and 139, then you do lifestyle changes plus one antihypertensive drug. Stage 2 hypertension is going to be a systolic blood pressure above 140 with a diastolic above 90. In that instance, you do lifestyle changes plus 1 to 2 antihypertensive drugs. 2-drug combination is recommended. Now, which 2 drugs are you going to choose? You always want to choose 2 drugs from different classes. So the classes that you have available to you are going to be ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, and thiazide diuretics. When it's monotherapy, you can choose any of those depending on what's going to be best for the particular patient. When you have 2 of them that you want to combine together, you're never going to combine ACE inhibitors and angiotensin II receptor blockers because of the risk of hyperkalemia and nephrotoxicity. One combination that works very well is an ACE inhibitor and a calcium channel blocker. The reason for that is because the ACE inhibitor can minimize the edema that's associated with the use of calcium channel blockers. When do you use a beta blocker in a hypertensive? You use a beta blocker if there are specific indications for it, such as coronary heart disease or heart failure with depressed ejection fraction. The other possibilities that you have are long-acting nitrates with hydralazine. This is a combination that you use specifically in patients who cannot take ACE inhibitors or ARBs. Contraindications for ACE inhibitors or ARBs include pregnancy, bilateral renal artery stenosis, a history of angioedema, and hyperkalemia. All right, this is for the CCS cases. Let's say you have a woman who presents with nausea, vomiting, and amenorrhea for 7 weeks. She's most likely pregnant. First thing you do, get a beta HCG, right? So first what I'm going to do is I'm going to talk about the full management of pregnancy, and then I'm going to talk about how do you approach it on the CCS cases because we're under a time limit, okay? And we want to do the most important things. So first, let's talk about the whole entire management of pregnancy, right? So the first thing, obviously, get a pregnancy test. Next thing you're going to do is get a pelvic ultrasound or a transvaginal ultrasound to confirm that it's an intrauterine pregnancy. You can, with a transvaginal ultrasound, you can detect the fetal heartbeat as early as 5 to 6 weeks. So this woman has 7 weeks of amenorrhea, so you may be able to detect the heartbeat. Go ahead and get the transvaginal ultrasound. There are some people that say that in the physical exam, you inspect the vulva and the vagina looking for Chadwick's sign, which is basically a bluish discoloration on the vulva and vagina. In real life, we don't have to do all that, right? Get the urine HCG or the serum HCG and call it a day, okay? All right, next thing you're going to do is once you confirm that the pregnancy is there, okay, you got the beta HCG, you did the transvaginal ultrasound, you confirm that it's intrauterine, it's good to go. Next thing you need to do is prenatal labs, all right, prenatal labs, and we're going to be screening for basically all the things that can cause the most danger to mom and fetus. First thing you're going to do, blood type. rhesus type, antibody screen on top of that. Okay, so just because you have the blood type and your rhesus type doesn't mean that you're clear to go in terms of the antibody front. So you still do the antibody screen. CBC, BMP, same thing you do with everybody. Get a pap smear, get rubella status, so you're going to get rubella titers. Get the syphilis screening with the RPR. Get a UA and a urine culture to screen for UTI. Get a hepatitis B surface antigen. Get HIV testing and get chlamydia testing. Those are the things that you do for everybody. Then there are additional tests that you're going to do for people who are at risk for the particular things we're going to talk about. Gonorrhea, tuberculosis, red cell screening for thalassemia, hemoglobin electrophoresis, in case there's any family history or patient history of sickle cell or thalassemias, hexosaminidase A, cystic fibrosis carrier testing, serum phenylalanine level, toxoplasmosis screen, and hepatitis C antibodies. This is reserved for specifically if you have a patient that's at risk for these things. Next, we get all these prenatal labs. Now we got to do prenatal counseling. So you're going to talk to them about the number and the frequency of prenatal visits, which is essentially going to be every 4 weeks. It usually is going to be in the, is going to get at closer intervals the closer you get to delivery. Okay, so around the third trimester is going to be about every 2 weeks. Recommendations for nutrition and weight gain, rest and sexual activity, routine pregnancy monitoring, so doing, regular ultrasounds on a regular basis, listeria precautions, which has to do with like the soft cheeses and the whatever other things listeria precautions are, toxoplasmosis, don't play with cats and cat poop, abstinence from alcohol and cigarettes and drugs, information about commonly used non-prescription drugs, what they should stay away from, seat belts, breastfeeding recommendations, all that other stuff. Okay, follow-up visits, glucose screening. All right, all pregnant women are going to get a 50-gram 1-hour glucose tolerance test between 24 to 28 weeks gestation. If it's greater than 135, it's abnormal. Okay. Now, if they have risk factors for diabetes, they should be screened at the first prenatal visit. So we're not going to wait for that 24 to 28 week point. All right. Indications for this are going to be if they're greater than 25 years old, if they have obesity, if they have a family history of diabetes, or if they had a previous infant that was born at greater than 4,000 grams, or recurrent spontaneous abortions. Last thing you're going to do right before delivery starts to come up at 35 to 37 weeks gestation, you're going to do a GPS screen, right? So that's the overall idea of the management of pregnancy. Now let's think about how we're going to approach this specifically in a CCS case. First thing you do, complete physical examination. Why? Not really sure. Just do the complete physical examination. Do everything. Next thing, you do urine beta HCG. Do it stat. Boom. You get the result. Positive. Cool. Next thing, transvaginal ultrasound. Confirm that it's intrauterine. Next thing, you do all the things. You do all the prenatal labs that are necessary for every woman. So let's go through that again. Blood type, road type, atypical antibody titer, CBC, BMP, pap smear, urinalysis, urine culture, rubella antibodies, RPR for syphilis, hepatitis B surface antigen, HIV ELISA test, and chlamydia screening. Those are the tests that you're going to do. Now, what are you going to give them as therapy? Always start them on prenatal vitamins immediately. Iron sulfate and folic acid. Those three things need to be included. In addition to that, we need to talk about treating the symptomatology that they came with. Let's say this person came with nausea, vomiting, and constipation. Don't just leave them like that. All right. For a woman in pregnancy, safe anti-nausea medications are going to be on Dansitron. Safe anti-constipation medication is going to be Docusate. Give that to her. Okay. If she's a smoker or if she drinks or anything like that, smoking cessation, alcohol cessation, good to go. Send them home. All those orders that you did, routine. You don't have to do a stat. Routine, send her home. She knows she's pregnant. All right, we confirmed it. Next, schedule an appointment in about 4 weeks. Okay, schedule an appointment in 4 weeks. By that time, you're going to get all the test results. You got the ultrasound, confirm the pregnancy, and the case, put the diagnosis, intrauterine pregnancy. You're done. right? Let's say you have a psychotic patient. They began taking antipsychotic medications. Okay. With these antipsychotic medications, they start to experience restlessness. They want to move. They can't sit still. They're pacing back and forth, X, Y, and Z, right? This is akathisia, right? Akathisia. Commonly with first-generation antipsychotics, but it can happen with second-generation antipsychotics, such as risperidone. So what's the first thing you're going to do? You're going to lower the dose of that antipsychotic medication, but you have to watch them closely, okay? Because their psychotic symptoms could come back. So let's say their psychotic symptoms do come back. Okay, fine. We're not going to go that route of lowering the antipsychotic medication. We bring back the dose that we had them on initially. But they still have this problem of akathisia. All right? Don't look at this and say, oh, they're getting more psychotic. No, right? They'll do things like shaking a limb constantly. You know what I mean? Or just get up and can't move around, right? They're not having specific like auditory or visual hallucinations or anything like that. What do you do in this situation? You can add a beta blocker such as propranolol. Propranolol is the one we like to use. Other things you could use are benztropine or benzodiazepines as well. But go ahead and don't discontinue any of the antipsychotics. Just add the propranolol on top of it, okay? All right, so you got a guy that comes in, sudden, acute, severe abdominal pain. Bang. He doesn't want to move. It hurts so much, okay? He has a history of GERD and hypertension, okay? GERD and hypertension. He comes in, you touch his abdomen, he wants to punch you in the face. All right, marked tenderness to superficial palpation. Okay, he's guarding. So what do we think? Two main things came across my mind, right? Ruptured abdominal aortic aneurysm and perforated intestine, perforated stomach, likely from ulcers, right? How do you tell the difference? If it's a ruptured AAA, there's going to be profound hypotension. This guy's hypotension not hypotension. This guy's blood pressure is not that bad, so it can't be that. Okay? So it's definitely a perforated viscus. What are you going to do to confirm it? Upright chest and abdominal x-rays. You're going to find pneumoperitoneum, free air right under the diaphragm. That's going to confirm the diagnosis. Send him to the OR. What are you going to do for this guy in preparation for the OR? Well, draw some labs. You may most likely see elevated white count. Okay? He just perforated into his peritoneal cavity. Give him intravenous antibiotics immediately. Give him fluids immediately. Okay? Broad spectrum. Cover all the gram-negative organisms. You can add an intravenous PPI on top of that as well. Okay?